Sir, I met you when I came to Darbhanga, I think. Darbhanga.
Yeah, good
And
evening,
after
sir. Good evening, Dr. Vijay,
NK
sir.
Singh, sir. NK Singh, sir,
Yeah.
tomorrow looking forward to the diabetes case files. Tomorrow.
Oh, yes, sir. Yeah, tomorrow, sir.
Good evening. Good evening.
Good evening, sir. Good evening, sir. Dr. Sudhir is there, Dr. Vijay, Dr. VK Singh.
सबसे पहले तो जीत
सर गुड इवनिंग सर, प्रणाम सर।
अपार बधाइयाँ।
Thank you, sir. Thank you all.
पीके अपार बधाइयाँ, ईसी मेंबर।
वो तो राजे, he the king maker and king. Yeah.
Congratulations.
Now he
Thank you sir.
he needs somebody to push to be his courtiers.
ठीक सर, वो विजय विश्वनाथन सर भी ज्वाइन कर लिया। ठीक सर, सर भेजे हैं आपके पर्सनल पे भी भेजे हैं सर। वो जूम का ये करके वो सिर्फ लेटर डालिए ना सर, उससे भी हो जाएगा जितना वो ये नंबर है। लाइन पे रहे सर। हाँ, वो नंबर डाल के। गुड इवनिंग सर।
गुड इवनिंग, नमस्ते।
वेलकम सर।
नमस्ते टू वन एंड ऑल।
Good evening to all, sir.
गुड इवनिंग टू ऑल।
बेताब गुड इवनिंग।
Good evening, sir.
आप जाना दरभंगा का।
ठीक है दरभंगा, आप छोड़ के गए हैं, चल रहा है।
सर गुड इवनिंग। गुड इवनिंग।
गुड इवनिंग।
जस्ट 2 मिनट है सर, 8:30 वी विल स्टार्ट।
ओके,
8:28 हुआ है।
यहाँ टाइम पे स्टार्ट कर देना ठीक रहता है।
हाँ यस सर, एकदम बिल्कुल 8:30 स्टार्ट कर देंगे सर। सब मेंबर्स हैव ज्वाइन।
सुजय से बात हो गई है ना?
हाँ सर, हो गई है सर।
Our secretary is very punctual.
साढ़े 8 बजे खाना।
गुड इवनिंग सर।
Good evening. Good evening.
सर गुड इवनिंग। सवाल सर गुड इवनिंग।
Good evening, Shabal.
Good evening, everybody.
Where is your handsome face? Yeah. Now it's
Good evening, sir. Good evening, Vijay sir. Good evening.
Good evening, sir. Satyawal, Dr.
Make us a
Vijay
evening.
here.
गुड इवनिंग कर लो और पीजी को भी लिंक दे दो।
Good evening to all the
हाँ
listeners.
तुम भी ज्वाइन कर लो।
गुड इवनिंग सर।
So it is 8:30. You can start. I think.
सर जस्ट स्टार्ट। अच्छा सर, फोन से कर लीजिए ज्वाइन सर, अगर उससे नहीं हो रहा है तो फोन पे सीधा वो लिंक को क्लिक करिए। ठीक सर, एक मिनट वेट कर लेते हैं सर। जस्ट चैप्टर चेयरमैन इज ज्वाइनिंग, एक्चुअली सम प्रॉब्लम, टेक्निकल ग्लिच। जस्ट विद इन हाफ मिनट ही इज ज्वाइनिंग।
Okay.
जस्ट
Good evening, everyone.
Good
NK
evening.
Boss, very good evening.
Yeah, Dr.
Just Abhishek, Dr. Abhishek, please wait.
Nagrath is here, yes.
Nagrath. Sir, good evening, Nagrath sir.
Hello, very good evening, Dr.
Hello.
Vijay. How are you?
Oh,
So,
Devariya
Priya,
King
good
has
evening.
joined, yeah. Yeah,
Hello. Hello.
Supriyo sir.
Very
Supriyo
good
sir,
evening.
you might have joined, sir. Good evening, sir.
yeah,
So we
yeah,
were
Dr.
waiting for you,
Supriyo.
sir.
Yeah,
So,
welcome.
so should we start, sir?
Supriya
Yes.
has-
Yes, good.
So, on behalf of RSSDI Bihar chapter, I welcome all the respected faculties, respected members to this virtual CME of our chapter. As we all know that RSSDI is committed towards academics and research in the field of diabetes, and in alignment with that, and in continuity to its endeavor of academic commitment, we have organized a virtual CME, and we are fortunate enough that our national president is with us to bless us on this occasion. So we have two scientific sessions today. So to proceed ahead, may I request our chapter chairman, Dr. Supriyo Mukherjee sir, to welcome our national president and all the faculties and members. Please,
Thank
over
you,
to
Dr.
Supriyo
Vijay.
sir.
Thank you, Dr. Vijay. It's my privilege, respected dignitaries and dear colleagues, on behalf of RSSDI Bihar chapter, I extend a warm welcome to today's virtual CME. We are privileged to have with us our national president, Dr. Vijay Vishwanathan, Vice President, Professor Dr. Sujay Ghosh, our newly elected Vice President, Dr. N.K. Singh, our newly elected member, Dr. B.K. Singh, our chapter chair-elect, Dr. Shaival Guho, our vice chair, Dr. Shubhash Kumar, and our treasurer, Dr. Manish Kumar, and our dynamic and young secretary, Dr. Vijay. We are equally honored by the presence of our esteemed patrons, distinguished faculty, panelists, members, students, and guests. Today's program features a case presentation, interaction discussion, and a keynote on heterogeneity of diabetic kidney disease by the renowned Professor Dr. Sujay Ghosh. Thank you all for joining. Your presence makes this event truly special. Let us now begin the proceedings. Thank you so very much.
Thank you, sir. So let me avail this opportunity also to congratulate on behalf of our chapter to all the winners of recent RSSDI elections, especially our Vice President-elect Dr. N.K. Singh sir, who is there with us tonight, and
Thank you, sir. Thank you.
Dr. B.K. Singh sir, as a zonal member, is zonal EC member, who is also there with us. So may I request Dr. B.K. Singh sir to address the gathering and welcome our national president and all other faculties and members, please.
Thank you, Vijay. Am I audible?
Yes, sir.
Yes. Thank you, Vijay, and good evening to all of you. And respected our national president, Dr. Vijay Vishwanathan ji, and Vice President, Dr. Sujay Ghosh, and Vice President-elect, Dr. N.K. Singh, sir, and Executive Committee member, Dr. Dinesh Agarwal, and all the faculties here, and the chapter chairman, Supriyo Ghosh, vice chairman, Shubhas, and chairman-elect, Dr. Shaival Guha, and all respected dignitaries present in this platform. The basic fundamental aim of this particular CME is that Bihar chapter always wants to do something new, particularly to upliftment of the RSSDI as a whole and East Zone as a particular. And this CME is only meant for that our East Zone should be properly represented in the national RSSDI platform. So we have invited all the persons who are neighboring the Bihar states like Jharkhand, like UP, like Northeast Assam, Bengal, and so on. So this with this remark, I think that the Bihar chapter will do many such type of CME and the workshop or the research orientation program to the members of the not only the Bihar but adjoining states of Bihar also. And with these words, I personally welcome all of you on this platform, and thanks to all of you for choosing me as the East Zonal member of RSSDI. Thank you very much.
Thank you, sir. And we are committed for our academic activities. And on behalf of Bihar chapter RSSDI, I assure you that we have several scientific activities in pipeline. And in coming months, we will do one by one all the activities. So now it's my privilege to request, welcome, and invite our National President, Dr. Vijay Viswanathan, sir, to grace the occasion by his blessings. So
Dr.
over to
Vijay
Vijay
Kumar,
Viswanathan, sir.
I'll take only 30 seconds. Dr. Supriyo Mukherjee, who is the chairman of the RSDI Bihar chapter, Dr. Vijay Kumar, who is the secretary, and Dr. B.K. Singh, EZO member elect RSDI. I would inaugurate this session of CME. I think RSDI Bihar chapter is doing a wonderful work, really wonderful work in the research field and also in the field of education of patients, of people with diabetes. So I think that's what we need. The RSSDI is looking for education and research, two words, education and research. And this is being done beautifully by your entire stalwarts. And Sujay has just joined, Sujay Ghosh. We're waiting for you, Sujay.
Hello, sir. Good evening.
Welcome, Sujay,
So I think the RSD Bihar chapter is growing rapidly under the leadership of so many stalwarts. And I'll be a part of the National Executive Committee after 31st of December. I'll be still a Executive Committee member as B.K. Singh sir and N.K. Singh sir and all the people and the great people. I'll also be a Executive Committee member as an immediate past president to Anand Maheshwari. So I will encourage research in a big way. And I think RSDA Bihar chapter is doing good work already in research. And you should grow with so many stalwarts. You should grow rapidly, more rapidly. And I am for RSDA Bihar chapter. And you should beat out Tamil Nadu and you should beat out West Bengal. Sujay Ghosh is doing too much of work for type 1 diabetes. You should beat out Uttar Pradesh and it should Bihar. Everybody should talk about RSD Bihar chapter. So with those words, I would like to inaugurate the CME program on this beautiful day of 18th July, 18th October. Thank you very much.
Thank you, sir. Thank you for your blessings and kind words. We are committed for academic activities and under the able leadership of our chapter chairman, Dr. Supriyo Mukherjee, our national figure, Dr. B.K. Singh, and all other senior dignitaries, we are doing day by day, we are improving and we are doing scientific activities. So, to proceed ahead, may I now invite for the first scientific session, that is a case presentation by a PG student from Lord Buddha Medical College, Saharsa. And chairperson for this session is our chapter chairman-elect, Dr. Sehwal Guha sir, and mentor of this PG, Dr. Amit from Saharsa. So before that, just may I request our technical team for a Saraswati Vandana. Mr. Anand ji, please play Saraswati Vandana.
वन्देन्दु तुषारहारधवला श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Thank you, Anandji. Now, our Dr. Sehwal Guha sir, chapter chairman, RSSDI Bihar chapter, and mentor of the PG, Dr. Amit Kumar, to kindly invite the panelist of the session and speaker of the session, please. Over to you, Sehwal sir.
Right. Good evening, all the respected seniors, dignitaries, and luminaries of RSDI, the national body. It's a privilege to have all of you today in this academic session. And I would take the opportunity to invite our panelist, respected Dr. Varesh Nagarath sir from Deoria and Dr. Sudhir Chandra Jha sir from Sitamarhi. Welcome you, sir, as panelists in this session. And I will also welcome my co-chairperson, Dr. Amit from Saharsa. And without wasting time, I would also invite our young doctor, Dr. Abhishek Verma, to start with his case presentation.
Over to you, Dr. Abhishek. Yeah, please start sharing. Yeah, you are audible.
Good evening, respected doctors. I am Dr. Abhishek Verma. Today I am here to present one case report. I am a resident, General Medicine Department, second year, and I am studying at Lord Buddha Koshi Medical College, Saharsa. So I examined the case on 8th of September. The name of patient was RD.
आनंद जी प्रेजेंटेशन थोड़ा
सर अपना वीडियो को ये ऑफ कर दीजिए सर अभिषेक सर एक्चुअली आपके वीडियो से सर
Now, sir. Is it okay now?
You can start,
Yeah,
you just start,
that's
not
better.
fine. Now it is fine, you can continue.
Continue, Dr. Abhishek.
Okay, so I examined the case on 8th of September 2025. The name of patient was RD. For the privacy purpose, the name is hidden. Patient was 37-year-old female. She was housewife by occupation. Her education was till 10th standard. She reside in Madhepura, Bihar. So the chief complaints were increased frequency and burning pain in urination since 7 days and bilateral lower limb swelling since 5 days. History of presenting illness was the patient was apparently well 7 days back. Patient developed burning micturition associated with increased frequency and urgency since 7 days. She noticed bilateral pedal swelling initially around the ankles, now extending up to mid-shin. It is pitting in nature since 5 days. She also noticed gradual onset, progressive hearing loss, initially difficulty in hearing conversation in the crowded place, now requiring repetition. There was no history of fever, chills, flank pain, facial puffiness, abdominal distension, difficulty of breathing, cough, palpitations, chest pain, hematuria, or vertigo. History of past illness. Patient was having type 2 diabetes mellitus since last 5 years. Since last 1 year, there was history of surgery of bilateral tubal ligation in the year 2018. No other significant past history was there. Treatment history. The patient was on regular insulin and injection basulog. Patient was taking Alma AM 40/5 and patient is taking Thyronorm tablet 25 microgram. Family history. Patient's father was suffering chronic kidney disease. He died at the age of 55 years. Patient's mother, she is suffering from type 2 diabetes mellitus. There is no significant menstrual history. Personal history was as follows. Patient is non-alcoholic, non-smoker, no drug abuse, normal sleep and appetite, no history of weight loss was there, regular bowel and bladder movement, and patient is non-vegetarian. Socioeconomic history. According to Kupuswami's socioeconomic scale, patient belongs to upper middle class socioeconomic status. Physical examination. In that general examination is as follows. Appearance wise, patient is thin built. The blood pressure was 150/90 millimeter of Hg in right arm on the sitting position. The pulse rate was 98 beat per minute at the time of examination. Respiratory rate was 20 cycle per minute, which was regular. Thoraco-abdominal pattern of breathing was there. Patient was febrile at the time of examination. Pallor was present. Bilateral pedal pitting edema was present. No icterus, no clubbing, no cyanosis, and no lymphadenopathy. General examination was as follows. On head examination, no asymmetry and deformities was there. Eyes, anicteric sclera. Ear, no cuts, abrasion, or other external deformity. Nose and throat, no nasal septal deviation, no oral ulcer, and normal mucosa. The systemic examination is as follows. CNS examination was patient is coherent and conscious, well oriented to time, place, and person. GCS scale was E4, V5, M6. No muscle wasting was there. Normal gait. Patient was having normal gait. CVS examination findings are S1, S2 was present. Apical impulse, fifth intercostal space, mid-clavicular line. No murmur was heard. Respiratory system examination findings are symmetrical chest expansion, bilateral air entry present, normal bronchovascular sound heard, trachea centrally placed. Per abdominal examination findings are it is soft, non-tender, no organomegaly, bowel sound present, abdomen symmetric. Investigations were done. Ophthalmologic examinations findings were as follows. Visual acuity 6/18 in right eye, 6/12 in left eye, mild non-proliferative diabetic retinopathy, anterior anticonus. These findings were on the 11th March 2025. ER examination findings are as follows. On pure tone audiometry, low frequency bilateral SNHL, sensory neural hearing loss was there. These are the investigations that were to the patient, and whatever the significant findings are there, which I found, it is mentioned in the upcoming slide. As we date on 2nd of May and on 10th of July, the spot urine protein level was 55 milligram deciliter and 266 milligram deciliter respectively, and 24-hour urine protein level was 990 milligram deciliter and 3,990 milligram deciliter respectively, which is increased from the normal level. The PT-INR value was 17.6 and 1.33 seconds respectively. On 1st August, the report of 1st August 2025 was showing urinary albumin level was 5,165 milligram per deciliter. Urinary creatinine level, albumin to creatinine ratio was 4,455 milligram per gram of creatinine. The 2D echo finding which was done on the 19th of March is as follows. No left ventricular RWMA was there. Normal left ventricular systolic function. Ejection fraction was 55%. trace MR was present, no air or tear, no vegetation, clot or pulmonary embolism. The CBC findings which is mentioned here. So on respect mentioned date, the hemoglobin level which we can see is at the level of 8.9, 9, 8.6, 8.9 respectively. The key level is high, and the normal 9.5 on the mentioned respected dates. The creatinine level is 1.79, 1.92, 2.12, and 1.8 on the mentioned date. In LFT report, the significant we can see that albumin level is lower than the normal range, which is 2.4, 2.9, 2.5, 2.3 on the respected date. The ultrasound of whole abdomen was done. Lateral bulky kidneys with echogenic cortical parenchyma and accentuated SMD was there. Distended urinary bladder, minimal ascites, and findings suggestive of medical renal disease. The sample sent renal biopsy reports are awaiting. On the basis of above findings and blood report and symptoms, our differential diagnosis is Alport syndrome, chronic glomerulonephritis, IgA nephropathy, thin basement membrane nephropathy, focal segmental glomerulosclerosis. Our provisional diagnosis is Alport syndrome, diabetic kidney disease. Patient is no case of hypertension, type 2 diabetes, and hypothyroidism. So here are among the differential diagnosis. Clinical presentation, we will find that hematuria, progressive renal failure, sensory neural hearing loss, and ocular defect will be found in Alport syndrome. The extra renal manifestation like hearing loss and ocular defect, these are absent in the other differential diagnosis than Alport syndrome. And we can confirm our diagnosis of Alport syndrome by kidney biopsy, in which electron microscopy will show the basket VV appearance, that is GBM thinning and splitting and lamination. So in short, we can say these are the differentiating point I have mentioned, so that we can differentiate between the Alport, glomerulonephritis, IgA nephropathy, thin basement membrane disease, and focal segmental glomerulosclerosis. So in Alport syndrome, it is a type of familial glomerular syndrome, also known as hereditary nephritis. The mode of inheritance is 80% X-linked, 15% autosomal recessive, 5% autosomal dominant. It is due to the defect in collagen type 4. The clinical triad which is found in the Alport syndrome is microscopic hematuria, sensory neural hearing loss, anterior lenticonus. Investigation of choice is skin immunofluorescence, and on electron microscopy, we can see basket VV appearance. Here in the third picture, we can see that in Alport syndrome, there is abnormally split and laminated glomerular basement membrane. And next, we are coming to diabetic kidney disease. So what is diabetic kidney disease? Diabetic kidney disease is any kidney disease which occurs mainly due to diabetes. And what is diabetic nephropathy? It is due to the glomerular involvement due to the diabetes. To attribute renal failure to diabetes, these 5 findings should be present. That is retinopathy, that is 70% of type 2 diabetes mellitus patient, and 100% of type 1 DM patient, they will develop retinopathy. Patient should have hypertension, patient should have edema, proteinuria should be there, and absence of micro and macro hematuria. So in these 5 findings, if any one of this is present, if any one of these 5 is absent, then we cannot say that the patient is suffering from diabetic kidney disease. Here are the stages of diabetic nephropathy. Mainly diabetic nephropathy is divided into 5 stages. We can see in stage 1 and stage 2, the GFR level is more than 90 ml per minute per 1.73 meter square. urinary albumin excretion rate is less than 90 milligram per day. In stage 3, the first clinical signs of kidney disease will be found in the stage 3, where the GFR value will decrease and it will become less than 60 ml per minute per 1.73 meter square. The urinary albumin excretion rate will be 30 to 300 milligram per day milligram per day. Patient will have hypertension. And the stage 4 is but nephropathy. The stage 5 in-stage renal disease, in which GFR will be less than 15. Patient will have microalbuminuria, which is more than 300 milligram per day, and patient will be having hypertension. And the main treatment algorithm for managing the diabetic nephropathy is we should strictly control the HbA1c level, that is glucose control, and hypertension control. So as we can see in this chart, if patient will be having normoalbuminuria, that is less than 30 milligram per 24-hour urine albumin excretion rate, and if hypertension is not there, then we will assess and treat the CV risk factor, cardiovascular risk factor. If needed, aspirin therapy and statin therapy should be started. Smoking cessation, weight reduction should be taken care of. Our target should be to maintain the GFR, to stabilize the GFR, to maintain the albuminuria. Blood pressure should be maintained less than 140 by 90 mm of Hg. HbA1c level should be less than or equal to 7, and BMI of the patient should be maintained below or equal to 25. If there is microalbuminuria or overt nephropathy, that is urinary albumin excretion more than 30 in 24 hours, then the mainstay of treatment is ACE inhibitor or ARB inhibitor. These help in decreasing the albuminuria excretion, means albuminuria. It will be decreased with the help of ACE inhibitor and ARB inhibitors. And if the microalbuminuria or overt nephropathy, the urine excretion rate is not managed, then we can titrate the dose of ACE inhibitor or ARB accordingly. And we have to maintain the BP below 140 by 90. And we have to do the strict glucose control. In this way, we can manage the diabetic nephropathy. Thank you.
So, Sehwal sir, please.
Thank you, Dr. Abhishek, for a nice presentation of a case which is rarely seen. I would invite comments from the panelists, Dr. Nagraj sir and Dr. S.C. Jha sir.
Dr. Nagraj sir, first, please, sir. Dr.
Sir,
Nagraj
please
sir.
unmute yourself, sir. Nagraj sir, please unmute yourself. Thank you. Yes, now we can hear.
Abhishek, in the urinary examination, you mentioned that proteinuria was present. Were RBCs also seen in that urine? RBCs?
Yes, sir. Actually, yes, sir. RBCs was present. I forgot to add in the slide. I will rectify it. RBCs were present in routine urine examination, sir.
Did you try to find out the morphology of RBCs in the urine?
Sir,
because if they are dysmorphic or they are broken, it means the source is glomerular.
Yes, sir, glomerular.
Whereas in tubular cause of hematuria, the shape of RBCs will be well maintained. So always we should ask our pathologist to mention this thing about the shape of the RBCs, whether they are crenated, whether they are fragmented, whether they are broken. So this should be done. Second, you did not mention the BMI of the patient, or did you?
No, sir. I will rectify it. Yes.
When you are treating diabetic, then BMI is very important to keep in mind when we are deciding the drug. Did you do Weber test and Rene test to find out what type of hearing impairment was there?
Yes, sir. We took the help of ENT department, ENT resident, and they did the test. So they did, and the conclusive report is mentioned here that mild SNHL was present.
I think you should also have done Rinne and Weber test.
Rinne and Weber, you can do yourself also.
Yes, yes.
I did. Actually, it was mild frequency SNHL was there now. So on Rinne and Weber, it was not that sufficiently positive, I found.
Okay, the patient had anemia.
Yes,
Did you
sir.
try to find out the cause of anemia? Did you do iron indices, ferritin, B12, all these things, so that you can exclude a nutritional cause of anemia? Did you do that?
Sir, actually, serum ferritin level, these are advised, but the morphology of the RBC were mentioned in the report as normocytic normochromic. So I was suspecting that it is the anemia due to the chronic deficiency of nutrition.
You can yes, you can get normocytic normochromic anemia in iron deficiency also. It is
Yes.
not that you cannot get iron deficiency there.
Yes, sir.
So, right. And in stage 1 of diabetic kidney disease, you mentioned the EGFR more than 90. Actually, it should be EGFR more than 120.
Sir, actually, it is GFR, sir. EGFR, I haven't mentioned. It is a GFR value, sir.
Okay. Now, why was the INR high? INR. INR
Sir,
was 1.3.
yes, sir.
No, you
it is-
presented the case very well, no doubt about it. But just for my knowledge, I am asking you, tell me. You presented very well. Right,
Thanks,
so
sir.
these are the points I wanted to raise. Now, next panelist can come forward and give his viewpoint.
I will agree with Dr. Varesh that in your otherwise wonderful presentation,
Thank you, sir.
an important point lacking was comment on hematuria. Because kidney involvement in case of Alport syndrome, three things are very important. Microscopic hematuria, which may turn macroscopic, that is the initial presentation much before proteinuria occurs. Second is proteinuria, and third is end-stage renal failure. So that was, I think, one of the important omissions clinically. And secondly, I will like to ask Abhishek, how did you diagnose it a case of Alport syndrome? How
Sir,
did you mandate it? How did you stamp the diagnosis of Alport syndrome?
Well, actually, whatever the findings and clinical presentation was there, on the basis of that, I came on the differential diagnosis as I mentioned here. But the symptoms, which is ocular manifestation, that is anterior lenticonus, it is present. We took the help of our ophthalmo residents, and they shared the finding with us. And that finding and sensory neural hearing loss, this thing, and that protein.
Unless you do skin immunofluorescence or the renal biopsy, you cannot stamp the case as Alport syndrome.
Yes, sir. That's why I put a query.
This particular basket wave appearance of the basement membrane in case of renal biopsy, or more easy is to take a scrap from skin and do the immunofluorescence study. And basic point is to see whether type 4 collagens are absent or not. So you have not done that. And
Sir,
again, my question will be, why not it is diabetic entirely? You have not taken the help of genetic analysis also. You have not mentioned it either.
Sir, actually, on your first query, sir, that immunofluorescence test and biopsy, these are not usually done in our hospital. So we send the patient for sampling biopsy in Patna. So we are awaiting the biopsy report, sir. And,
sir, with due permission of chair, may I say a few words, sir? Dr.
Yes.
Estija, sir, the student has presented very well.
Excellent.
You are requested to kindly provide your valuable input so that he can improve in future.
Clinical correlation is wonderful. The combination of kidney involvement, eye involvement, sensorineural type of deafness, and the basic thing, it is of sensorineural type of deafness, and that we can do in ward itself by doing Rennie's test and this thing. This is not a great thing to be done. Okay, for the higher things, we can refer to ENT, but for branding it sensorineural deafness, we did not refer it to someone. Second thing is, we have to remember that it is a very rare disease. And for the rare disease, stamping the diagnosis by the proper method, well, you can just put a provisional diagnosis like Alport syndrome. You cannot brand it Alport syndrome.
Yes,
And
sir.
diabetes is one disease which encompasses almost all the organs in the body, and that may be the confusing part itself. Because since you did not mention about hematuria and you just mentioned about the proteinuria, proteinuria is the hallmark of the diabetic kidney disease.
Yes, sir.
So I will suggest to Abhishek a brilliant presentation, but I think clinically he should have gone for hematuria. And as Dr. Varesh Nagarath clearly pointed out, the shape of RBC and other things will be important. And secondly, the genetic testing is important. Immunofluorescence test of skin and renal biopsy is important. That we should have stressed more.
True.
Yes, sir. Yes, sir. I will do the follow-up, sir. I will advise the patient and I'll do the follow-up and I'll rectify it, sir. Thank you, sir.
Thank you, Abhishek, for a nice presentation. And I must say, you are lucky. Even before your MD examination, you got such wonderful tips from master teachers, and which I must admit, many of those points which Dr. Nagarath has pointed out may not have struck out in the mind of the other panelists as well. So thanks a lot, sir, for your inputs, both Dr. Varesh sir and Dr. Sudhir sir. And thanks, Abhishek, for a nice presentation. Over to you, Vijay, to carry forward.
Thank you, sir. Thank you, our chairpersons, Sehwal sir, Dr. Amit, and our panelists, Dr. Varesh sir and Dr. Yasija sir, for your valuable inputs and friendly discussion. And I must thank Dr. Abhishek Verma for presenting such a interesting case. So
you, sir.
congratulations, Dr. Abhishek. So we are proceeding to the next session. So for next session, may I invite our chairpersons?
Vijay Kumar, can I ask a question?
Sure, sir. Most welcome, sir.
Dr. Abhishek, it was a wonderful presentation. Was there evidence of any cast in the urine? C-A-S-T.
To rule out the tubular pathology, Abhishek.
Island cast, granular cast.
Sir, actually,
any cast in urine, granular cast or any cast in urine?
Important question.
yes.
That is very pertinent point.
Very important. Very important.
There's a patient for again
because that points towards tubular pathology.
The patient report was there, but you did not mention, I think. I have seen that cast. Patients having tubular, sorry for interruption. I have seen also this case in my emergency department. So they have some reports regarding renal cast was there. So I think he missed that point.
Any other input, Vijay sir? Any other query, Vijay sir?
Can I just make a couple of comments, please?
Sure, sir. Most welcome.
Right. So first of all, thank you for a very interesting case. Couple of things that you strike out very clearly is the liver involvement. This individual in all likelihood has got chronic liver disease. You've got low albumin level. Why is that? How do you explain that with Alport syndrome? Remember, you are banking your diagnosis only on the lenticonus. Sensory neural deafness can happen even in type 2 diabetes.
Yes.
So, diseases like hepatitis B, hepatitis C, I don't know what the serology report was, even that might present with both liver and renal involvement with presence of high levels of proteinuria. Now, one of the other things that stuck out was you stated that the kidney disease, the kidney sizes were normal. So here you have a situation, you have to think of all the differential diagnoses where the kidney size is normal, you have both liver as well as kidney involvement, which could be autoimmune in nature, which could be vascular in nature, which could be amyloidosis due to some cause. So I think even more detailed evaluation of the liver is also required before we jump into the diagnosis.
INR was high. INR was high.
So there is definite liver disease. So in Alperts, you don't expect that the liver disease is going to be there unless and until there's something called a Fletcher's variety of Alperts, which is very, very, very rare. So I would try to figure out, I don't know whether, do you have reports of serology? Do you know hepatitis B status? Do you know the hepatitis C status? Any evidence of amyloidosis? Any evidence of connective tissue disease?
Yeah, vasculitis was there. That
While
patients having vasculitis.
Sorry, Sujay
Priyanka
sir, you
Singh
can
covered
suggest
for
the investigations. Actually, the patient is right now in his ward.
Right. So
they can carry on further.
look for hepatitis B, hepatitis C, evaluate the chronic liver disease because INR is increased, albumin is low. So there is some kind of liver disease going on. Look for varices. What is the portal vein diameter? Is the ultrasound telling you or any imaging telling you whether there is any nodularity of the liver? Because this seems to be a disease where you've got both liver disease as well as renal disease. We've discussed the liver disease, we've talked about liver biopsy as well, but I think I would more try to figure out what has caused the liver disease. That might give me a better clue into the renal disease.
That is a very important thing.
Thank you, Sujay sir, for your valuable inputs. Of course, these are the learning points, and the patient is still in their ward, so they might work up on that angle also. So,
yes, sir. Hypoalbuminemia, Dr. Sujay, can be explained by the nephrotic range proteinuria which the person is having.
There is only mild edema of the patient, if I'm not mistaken. For someone to have severe nephrotic syndrome with hypoalbuminemia, the presentation will be a little bit more, profound.
But ACR is very high. I think he has mentioned more than 4,000.
We see people with 4 grams proteinuria. Not every, you have nephrotic range proteinuria, but the patient does not have nephrotic syndrome. That's the point that I'm trying to make. And the INR would not be, altered in someone with nephrotic syndrome.
And there's a one passing comment that nephrotic range proteinuria is not a very common presentation of Alport.
Yes, exactly.
It is a hematuria, which is the commonest. Nephrotic range it is present only in a very recessive disorders, or it is an X-linked disorder. It is basically very rare to find it.
And if you have massive proteinuria, the other diagnosis with a normal sized kidney is what about the renal veins? Have you had renal vein thrombosis or something like that? The kidney size will be preserved. That could be another pathology from the liver disease which has happened, which could lead to the proteinuria as well. So I'm still a bit skeptical that we've got the final answer. And remember, isolated lenticonus is not very uncommon. It's just because, at least as an internist, I do not look for lenticonus. Isolated lenticonus is not that rare.
So, Dr. Abhishek, please keep note of all these inputs.
Yes,
and
sir.
These are the valuable inputs and learning points for further diagnosis to conclude. So thank you, our guest faculty, Sujay sir, Supriyo sir, for your valuable inputs. Now, to proceed ahead, we are proceeding to the next session. That is a guest lecture by our Vice President, Dr. Sujay Ghosh. So, to conduct this session, may I request our chairpersons, after chapter chairman, Dr. Supriyo Mukherjee sir, and chapter secretary, RSSDI Jharkhand, Dr. Ajay Patwari sir, to kindly invite our panelists and speaker, please. Over to you, Supriyo sir. Sir, please unmute, sir. Supriyo sir, please unmute.
Yeah, it's absolutely pleasure. It's absolutely a pleasure to invite our revered panelists, Dr. N.K. Singh sir and Dr. Dinesh Agarwal. And Professor Sujay Ghosh truly requires no introduction. A leading figure in Indian endocrinology and one of the most respected academics in the country. He has contributed immensely to the field of diabetes care, research, and education. He is widely admired for the conceptualization and implementation of West Bengal model of type 1 diabetes care, a pioneering initiative within government hospitals. This model has been recognized by the International Society of pediatric and adolescent diabetes, that is ISPAD, and has inspired similar program across India. It is now my privilege to invite him to deliver his talk on heterogeneity of diabetes kidney diseases, a subject which he brings unparalleled insight that I know from very beginning, from the Barcelona and all, that he was presenting for last 10 years, a decade probably, and his insight and his expertise. Over to Dr. Sujoy Ghosh.
Dr. Supriyo, if I can add one word. Dr.
Sure, sure, sir.
Dr.
Sure,
Supriyo
sir.
Ghosh is the president of the Endocrine Society of India.
Yeah.
Oh.
So recently elected president of the
Absolutely.
Endocrine Society.
And I think Vijay sir, one more feather here is that he has received a very, very prestigious award from the SPARC, international award for the Sujoy Ghosh. So I think today we are really lucky that we have got a figure in India like Dr. Sujoy Ghosh. So welcome Dr. Sujoy Ghosh. And today's I think topic is also very, very exciting. So with my I think Secretary of Jharkhand, Dr. Ajay Patwari, Dr. Dinesh Agrawal is also congratulations to Dr. Dinesh Agrawal also.
Thank you.
And I think you people are doing a very wonderful job from today. That you are lucky that our president has inaugurated, and we will not get a man like him in all over world. I think he is so great. So, sir, with thank you, sir, for all. And now I will request Dr. Sujoy Ghosh to start.
So first of all, with humility, I would thank everybody for the praises, and a big congratulations to the Bihar chapter of RSSDI for organizing a meeting like this, where you've brought the entire East India's who's who in under one umbrella. And I think we should continue to do this. Next is big congratulations to all the newly elected EC members.
Thank you, sir.
We'll start their tenure from 1st of January next year. And I have been, I think, allocated about 15 minutes for the talk. So please excuse me if I overshoot time, because there's a lot to talk about.
Yeah.
So I'll be trying to talk a little bit about whatever work we have been doing in the kidney space. So hopefully my slides are visible in full screen,
Yes,
and I'm audible properly.
Yes, sir. Both audible,
Yes,
audible
sir.
and visible.
Thank you so much.
Absolutely.
So I'm going to talk about heterogeneity of kidney disease in diabetes. And first of all, let us get a few terminologies defined. I think our junior colleague, who is an MD postgraduate, did a wonderful job. He did describe some of the terminologies, but for the sake of record, when we say diabetic nephropathy, it means persistent albuminuria of more than 300 milligrams in 24 hours on at least 2 occasions separated by 3 to 6 months. And at this stage, the patient invariably develops hypertension. So this is technically what we mean when we say diabetic nephropathy. Diabetic glomerulopathy, on the other hand, should be a term reserved for biopsy-proven kidney disease caused by diabetes. And when we talk about diabetic kidney disease, it's a presumptive diagnosis. We are saying that this individual has got chronic kidney disease and that it has been caused by diabetes. Again, remember, this is a presumptive terminology. We often in clinical practice tend to use these terminologies interchangeably, but diabetic kidney disease is what most textbooks would be talking about. But what in reality is kidney disease in diabetes? So first, it could be true diabetic kidney disease. That means that the kidney disease is caused by diabetes itself. The case that was illustrated, we are suspecting, is an individual who's got diabetes, who's got kidney disease, but we are suspecting that he's got kidney disease due to she's got some other reasons, or the so-called non-diabetic kidney disease. There will be a group of people who will have a bit of both. Some amount of influence of diabetic kidney disease, there might be something else as well. And we also have to think of that we keep on talking about albuminuric and non-albuminuric kidney disease. We'll talk about that a little later. So this was also discussed in the previous presentation, or the Mogensen classification of kidney disease, wherein you talk about stage 1, stage 2, stage 3, stage 4, and stage 5. Remember, classically, this Mogensen's classification is only for type 1 diabetes. Why am I mentioning this? So your patient might present straight away with stage 3 and not necessarily stage 1 and stage 2. So in type 2 diabetes, this is not necessarily followed. So this is UKpedia 64, wherein we thought patients will transition through this. That is no nephropathy, then microalbuminuria, then macroalbuminuria, and then a decline in eGFR. This does not necessarily happen in all of our patients. Now, this is again another very important concept, what I was trying to say, because we were taught as if, you got to develop albuminuria before the eGFR drops. And this is one very beautiful article that was published almost 20 years ago, that non-proteinuric diabetic nephropathy when the diabetics don't read textbooks. So the classical teaching was questioned even 20 years ago. So if you look at the histopathological classification of kidney disease, what is now followed is the American Society of Nephrological Pathology classification is what is followed. Even that is 15 years old. This renal pathology society classification is relatively standardized. All of the current clinical trials that are undergoing follow this particular classification. And it looks at three things. Number one, it looks at the stage of glomerular involvement. And there is this classification of 1, 2A, 2B, 3, and 4. The 3 is what we were taught in undergraduate and postgraduate days as the KW lesion, and the 4 was glomerulosclerosis. The second thing that you're supposed to look at is interstitial lesion, and the third thing that you're supposed to look at is vascular lesions. So every time you get a renal histopathology, insist that there is definitive mention of all of these three things. That is, what is the grade of glomerulopathy? What about the interstitial involvement? And what is the vascular involvement? And this has to be reported in this particular format. Coming to the next bit, that of non-diabetic kidney disease. At least when I was an undergraduate or an MD student, and when we used to read Harrison's or CMDT or Davidson's, we were taught, if you have 100 patients of diabetes with kidney involvement, only about 5% will have kidney disease due to causes other than diabetes. And when do you suspect? When there is no retinopathy, when there is low or rapidly decreasing GFR, when there is increasing proteinuria or nephrotic syndrome, refractory hypertension. We were discussing in the previous case about presence of active urinary sediments, whether RBC is there or not, signs and symptoms of other systemic disease, and if there is a rapid drop in eGFR. And these we were taught are the reasons why you should go for a renal biopsy. So if you had any of these indications, you start thinking of non-diabetic kidney disease and go for a biopsy. This is classical teaching. This is what we still have in our textbooks. Now, if you look at all of the prevalences of non-diabetic kidney disease, depending on who you are quoting, the prevalence of non-diabetic kidney disease can range from anywhere around 10 to 12% to 50%. There is a problem with all of these studies. These are all retrospective cohorts. These are nephrologists' cohorts. That means these are people who underwent biopsy depending on who the nephrologist thought might be having a non-diabetic kidney disease. So this is not unselected biopsies. And some of the later studies suggested, particularly European studies, that 1/3 of people will have kidney disease, which is not because of diabetes. Indian studies have also, in an unselected manner, had some suggestions of high prevalence of non-diabetic kidney disease. So what are the causes of these so-called non-diabetic kidney disease? They are the same causes as in an individual who does not have diabetes. So you will start thinking of obstructive uropathy, you will start thinking of primary glomerular disease, hypertensive disease, ischemic nephropathy, and all of the causes. So it's not rocket science, it's anything under the sky that can cause kidney disease. The next question, I think, which our junior colleague in the previous case discussion suggested, that about 70% of them will have retinopathy. Now, the association of retinopathy with kidney disease is much stronger in type 1 diabetes than in type 2 diabetes. So you will find that almost 90% of all DKD patients in type 1 will have associated retinopathy. The same does not hold true for type 2 diabetes individuals. And there is a dissociation between the renal involvement and the kidney involvement. Does that mean if you don't have renal retinopathy, the kidney disease is due to non-diabetic kidney disease? The answer is not that simple. Those individuals who did not have retinopathy and had kidney disease, if you did do a biopsy, about 70% of them still will turn out to be pure diabetic kidney disease. Now, why am I going on harping about these things? It is trying to tell you that at an individual patient level, whatever clinical parameter we have been taught to pick up non-diabetic kidney disease is rather unreliable. And here I come to our own data. We've been working for almost 8 years now. So we've looked at more than about 7,000 patients by now. And what we wanted to do is answer in the first study that I'm going to show you is what's the prevalence of non-diabetic kidney disease? Number one. Number two, is there anything in the clinical, biochemical parameters which will tell me that either this person definitely has diabetic kidney disease or this person is at a risk of non-diabetic kidney disease? So, you know, if you look at 100 patients with type 2 diabetes, about 30% of them will have some degree of renal involvement. Now, are you going to do kidney biopsies in all of them? The answer to that is no. So what we thought was, we will include only people in CKD stage 3 or those with ACR more than 300. Why? The ethics committee will never give you permission to do a biopsy in CKD stage 1 and stage 2. And if you do a biopsy in CKD stage 4 and stage 5, you will get a burnt out histopathology. So you will not be able to make out what is actually happening. So to cut a long story short, we found that there is very little differences between the groups in terms of all of the clinical or biochemical parameters. One difference, as you can see here, is age of onset, duration of disease, baseline hemoglobin. We'll come to these parameters. But the rest of the parameters that we have been classically taught that this will help me differentiate diabetic kidney disease from non-diabetic kidney disease is very, very difficult to actually differentiate. So these are the parameters which we found statistically to be different between the groups. And after a multivariate analysis, only two things stuck out. One was duration of disease and the other was presence of retinopathy. Now, in type 2 diabetes itself, you know, duration of diagnosis or duration of diabetes is a very unreliable parameter. And here also you see that the odds ratio is only 1.02. In terms of the retinopathy, the odds ratio is 18, but look at the confidence interval, anywhere between 1.2 to 277. Essentially telling us that either of these two parameters, even though statistically may be different, was useless at an individual patient level. So the patient sitting in front of me, will these parameters help me to differentiate between the two? The answer to that is absolutely no. So this study, we were able to show that at least 1/3 of our patients have some component of non-diabetic kidney disease. About 18% have pure non-diabetic kidney disease and about 15 to 16% have mixed kidney disease. And 2/3 of our patients have pure diabetic kidney disease. So what we were taught, say 5%, 10% is actually not correct. A significant proportion of our patients will have a component of non-diabetic kidney disease in the patients that we are seeing. Now, India has got what, 10 crore people, 11 crore people with type 2 diabetes. And we are saying 30% of them will have renal involvement. That means 3 crore people. And I'm saying 1/3 of them will have a non-diabetic kidney disease. That means 1 crore people. Will you be able to do a biopsy in so many people? Number one. Number two, like all microvascular complications, the screening has to be done on an annual basis. Are you going to do one biopsy every year? So you understand this is absolutely impractical in our setup. Now, if you were doing biopsies on the basis of the traditional indicators, that means what is there in, say, Harrison's textbook, that if you have X, Y, or Z, do a biopsy. If you look at those indicators, close to 80 to 90% would have satisfied the criteria for biopsy. And if you did do a biopsy in them, 2/3 of them would have turned up to be diabetic kidney disease. That means all your discriminators that you are there in your textbook to do a biopsy actually will lead to a diagnosis of diabetic kidney disease in 2/3 of the ones that you would do biopsy. So your clinical parameters and laboratory parameters that you are using to pre-select individuals to do biopsy is absolutely useless. Coming to the next point, depending on which study you are quoting, if you look at Wikipedia, somewhere around 40% had non-albuminuric kidney disease. But what we are seeing in our clinical practice is about 1 in 6 actually has non-albuminuric kidney disease. The rest have albuminuric kidney disease. So this study we published in the British Medical Journal. Now you might argue and say, okay, if you do have a non-diabetic kidney disease, what does it matter? I am going to treat the patient with an ACE inhibitor ARB. I'm going to control the blood pressure. I'm going to control the blood glucose. I'm going to add an SGLT2 inhibitor. I'm going to use a GLP-1 analog, and I'm going to use finerenone, and I'm going to save my patient. Am I going to do anything different if I find someone with a non-diabetic kidney disease? And if I do something different, does that lead to difference in outcome of the patient? So what we did was, this entire cohort that we talked about, where you had one group which had DKD, we treated according to the prevailing standards of care, and the other group, when we did the biopsy, we found out they had non-diabetic kidney disease. We gave them specific therapies, for example, steroids, immunosuppressives. So we gave it to the non-diabetic kidney disease group. And what we tried to look at was looking at composite renal outcome. Just like CV outcome for kidney disease, we all now look for composite renal outcomes. And I'll just skip the data. And we followed them up every 3 months and gave them standard treatment. And we included only those subjects in whom we had longitudinally followed them up for a minimum of 3 years. And then we looked at how many of them reached a composite renal outcome between the two groups. So this is the cohort and the flow diagram. In the composite renal outcome, if you see in the DKD group, 33 patients attained composite renal outcome, whereas in the non-diabetic kidney disease group, only 3 had a composite renal outcome. So if you again compare the two groups of DKD versus NDKD, there was hardly anything to choose between the two groups in terms of the differences at baseline. But look at the survival analysis and renal outcomes. Those with non-diabetic kidney disease had a far better composite renal outcome compared to those with diabetic kidney disease, in spite of the best standard of care of treatment for diabetic kidney disease. And the major difference was in the doubling of serum creatinine. Not many people had renal deaths or ESRD, but if you are talking about the progression of the kidney disease in terms of the doubling of the serum creatinine, there was significant difference between the two groups. And if you're looking at the decline in eGFR, you can also see that the DKD group had much worse decline in eGFR as compared to those with non-diabetic kidney disease. And amongst those with diabetic kidney disease, histopathologically, if you are looking at, RPS classification was the greatest predictor of poor outcome. So we looked at those outcomes as well. And again, after the ones that we found a difference, we did a multivariate analysis, and 2 things predicted poor renal outcome in those with diabetic kidney disease. Number 1, RPS stage 3 and 4, not surprising, because they had worse forms of glomerulopathy, and those with bad proteinuria. So that also we have published earlier in the year in terms of the composite renal outcome. So the next thing that we tried to look at is, how is albuminuric kidney disease and non-albuminuric kidney disease different? So traditional belief was that albuminuria happens before renal function deterioration. there is progressive decline in renal function in the absence of albuminuria. That we have found very clearly. That means non-albuminuric kidney disease will also progress to poor renal outcome and worsening of EGFR. The prevalence of non-albuminuric kidney disease in the past was stated to be as high as 20 to 40%, and the data regarding difference between biopsy-proven albuminuric and non-albuminuric kidney disease is almost non-existent in medical literature. So we have looked at about 3,347 patients, and we've looked at a biopsy-driven study to look at what's the difference between albuminuric and non-albuminuric kidney disease. And if you, I'll skip some of the slides for the paucity of time. You can see that the ones who have albuminuric kidney disease are more likely to have glomerulopathy. Whereas if you're looking at the tubulopathy is more common in those with non-albuminuric kidney disease. Not surprising. So glomerulopathy more common in albuminuric, and interstitial disease and inflammation more common in non-albuminuric kidney disease. So not surprising. So you can see that there is huge amount of variability in kidney disease in diabetes. So some people will have kidney disease actually because of diabetes itself. Others will have due to causes other than diabetes. And in some, there will be an overlap between groups. Some will have albuminuric, some will have non-albuminuric, some will have predominant glomerulopathy, some will have predominant tubulopathy. In some will have interstitial inflammation, some will have ischemic change. It is altogether a very heterogeneous disease. Now again, what we were talking about in terms of the progression, if you look at here, the type 1, the onset of the disease and the DKD is relatively predictable. And therefore in type 1 diabetes, if you're talking about kidney disease, is it an inherited disease or is it an acquired disease? It is perhaps a bit of both. You have an inherited genetic predisposition and you have an acquired poor glycemic control in type 1. So if someone with type 1 diabetes has not developed kidney disease, say 20 to 30 years after the onset of type 1 diabetes, you can almost certainly say that that person will not develop kidney disease in his lifetime. Whereas in type 2 diabetes, you cannot make such a statement. It is highly variable and highly unpredictable. And the old paradigm was you have hyperglycemia, you have glomerular hyperfiltration, you then have albuminuria, and you then have reduction in GFR. The newer paradigm you are all aware of because you are now using drugs like cefirinone, which targets fibrosis and inflammation. You have drugs like SGLT2 inhibitor that targets hyperglycemia as well as intraglomerular hypertension. The similar thing with ACE inhibitor ARB. You know there are other risk factors as well. And finally, this is published only about a month ago. Read this commentary in Nephrology Dialysis Transplantation by Peter Rossing and his group. It says, now they think that we should no longer call it diabetic kidney disease. Because of the facts that I talked about of all of these things, it says, instead of adding that confusion, call it chronic kidney disease. So someone who's got chronic kidney disease with a risk factor of diabetes. So therefore, the chronic kidney disease can be because of the diabetes, or it can be because of reasons other than diabetes, because the disease we now realize is so heterogeneous. I shall stop there for questions. Thank you very much.
As I have to leave, so I will give an initial comment.
Sure.
Dinesh and Dr. Patwari will be responding later on. So I think this was a very masterly presentation by Dr. Sujay Ghosh, and you have seen the volume and the contents and the your own research. So this is very, very important that he has not only given a theoretical talk here today, but he has also given us inputs and the way ahead that how we should proceed for such a condition. So as we are well aware that the diabetes heterogeneity or in kidney disease is so varied, and all patients with diabetes, not all patients develop this kidney disease, but among those who do, definitely we have to be very, very careful. And this definitely reflects the differences in pathophysiology, the clinical presentation, progression, and response to therapy also. So apart from just we should be aware ki what are the major phenotypes of diabetic kidney disease. I think all diabetologists must be very, very careful and should be updated ki how this happens. And he has clearly shown what happens with this albuminuric DKD and non-albuminuric DKD. So again, this point was great, and you have shown a very well how these rapid progressors or slow progressors in such cases, how the steep eGFR is declining and how the stable kidney function over years despite the long duration of the diabetes. So definitely there is overlapping of the CKD phenotype, and many diabetic patients definitely develop this hypertensive nephrosclerosis, ischemic nephropathy, or what you are talking about the now there is a MASLD rated CKD and so many complexities. So definitely there is lots of pathophysical heterogeneity also, and clinical implications that should be also we should be very, very uh, updated. Only in the diagnosis the albuminuria alone is not sufficient. We need many eGFR trends imaging. I think that Surya Ghosh has also worked on the biomarkers and in the DKD, and so that is a very, very important thing that I think sometimes we can request him to talk on these biomarkers. So I think you have given a very, very illuminating input on the prognosis, on the therapy and the real work. So we are really grateful. And I think with that, I will end here. So I think Dr. Dinesh Agrawal, your initial comment.
No, it's a wonderful talk as usual. He's rightly mentioned about the heterogeneity, the newer terminology, the difference between albuminuric, non-albuminuric, then DKD, non-DKD, and the mix. And now the new terminology like CKD with risk factor diabetes. So is everywhere everyone patient when seeing a type 2 diabetes patient or type 1 eGFR changes or urine albumin creatine ratio, everybody labels this as a DKD. So there is so much of heterogeneity. We have learned a lot from today's and his work that it's commendable. I think I do not have any question to ask him because so crystal clear presentations which has clarified everything to one all, I think. And anyone having any questions or we can always ask Dr. Sujay Ghosh and we can clarify this.
Yeah, so
Vijay sir.
There is an entity called CKD-U, which is very common in Sri Lanka, Tamil Nadu, Orissa, in some pockets of India. They don't know the etiology. So many of them are people with diabetes. So would you recommend kidney biopsy in them at least?
It's difficult to make a comment because the so-called CKD-U means where the etiology is unknown. Now, whatever we do should actually alter treatment or prognosis or outcome. Now, in CKD-U, by doing a biopsy, what will I gain? If it is already unknown, what will I gain in terms of treatment outcomes? Now, the question is, the situations where you will benefit from a biopsy is where you have a non-diabetic kidney disease, where there is a definitive alternative treatment options. And I have shown from our data that without doing a biopsy, it is very difficult to make that prediction. And the point that Dr. N.K. Singh sir was talking about is we need better biomarkers to tell us that in these cases either don't do a biopsy or in these cases do a biopsy. Until then, either a blanket statement about doing biopsies or a blanket statement of not doing biopsies, we are not there yet as clinicians.
Dr. Ajay Patwari, your initial comment.
Sir's presentation was really a very nice presentation. I don't think so any chances any questions are there. Dr. Sujay Ghosh, when he is speaking, he takes care to include all the points. But still, what he has shown is what I have seen here is that some means he has shown that like compared to non-diabetic kidney disease, diabetic kidney disease have a more faster progression, and even those patients with classical retinopathy may have non-diabetic kidney disease. Those with classical retinopathy, they may also have non-diabetic kidney disease also, and similarly vice versa also. I think so. Now the treatment it has to be individualized. There may be some change of even the changing of phenotypes may be there, and it has to be individualized. We cannot say that okay, proteinuria is there, it is diabetic kidney disease. Now it has to be treatment has to be individualized whether it is non-diabetic, because 45% he has shown in his data to be having either pure non-diabetic or mixed type of these things. So it has to be seen whether which patient has to go for biopsy. Of course, sir.
This is a cohort that we are following up. We are doing a multi-omics study. So we are doing metabolomics, we are doing transcriptomics, we are doing proteomics, we are looking at exosomes. So maybe 5, 7, 10 years later, I might, or even other people working elsewhere on earth, might give us better idea. My reason was not to confuse the physician. My reason was continue doing an EGFR and albuminuria, treat the way you are treating. But number one, remember that the criteria that you are using to pre-select biopsy is not sacrosanct. That is point number one. Point number two is we are not doing enough biopsies.
Right.
That is point number two. Point number three is that if you are able to diagnose non-diabetic kidney disease, their outcome is much better if you are able to treat them. Because or else will you and I have the courage to start something like a steroid or an immunosuppressive without a biopsy? I don't think so we can do that. Ethically, medico-legally, we cannot do it, particularly in an individual with diabetes. And to tell us that in the future, we will have to understand, just like say diabetic neuropathy. Do you think diabetic neuropathy is one disease? You now know that there is so many forms. Isolated autonomic neuropathy, distal sensory neuropathy, mononeuritis multiplex, amyotrophy. So we realize that there is that variety there. It's not that one thing that is happening. Mere fact that the kidney is involved, it is not an uniform, universal disease. That's the reason why I wanted everybody to think of it. And the second most important thing that we suffer is, I don't want you to look at your patient and say, oh, your EGFR today is 75, you don't have albuminuria, that means your kidneys are safe. You tell them as of now, we don't have reasons to worry. Because previously what we thought, okay, EGFR is 75, first the patient will develop albuminuria, then there will be overt proteinuria, then the EGFR will decline. So that does not happen. So it might happen unpredictably that straight from an EGFR of 75, without any albuminuria, the EGFR might drop to 55.
Sir, I have a question. Thank you for the illustrative talk. But sir, one query: in a type 2 diabetes mellitus patient with early microalbuminuria, but with preserved EGFR, how will you prioritize the integration of the diabetic drugs like SGLT2, RAS blockade inhibitors, or non-steroidal mineralocorticoid receptor antagonists to achieve the renal protection?
Right. So whenever you have a patient with type 2 diabetes now, unless and until there is a contraindication, everybody should get an SGLT2 inhibitor, whether there is albuminuria, whether there is renal involvement or not. So let us first accept that reality. Number two, good glycemic control is important, irrespective of what agent you are using. Third thing, achieve good blood pressure control. Now, with these three things, half of your mild albuminurias will disappear if it was there to start with. Because remember, albuminuria is not sine qua non of renal involvement. It might be a feature of endothelial dysfunction as well. So just the fact that somebody's got an isolated microalbuminuria to start with, don't start thinking that kidney disease is the only disease which has caused it. Thereafter, traditionally, as you and I have been taught, start an ACE inhibitor or an ARB, maintain the blood pressure. So sugar control, pressure control, preferentially with an SGLT2 and ACE inhibitor ARB. You've done that. And now you think there is albuminuria still persisting, then think of a mineralocorticoid receptor and antagonist. Now, in years to come, we may not think of such sequential therapy. Why? At present, we are thinking of sequential therapy predominantly because of the cost of therapy. If in future MRAs become as same price like a cheap SGLT2 inhibitor, at that point of time, you will again see people starting to use all three together. Again, remember, there is another class of drug which now has got renoprotective effects, that is GLP-1 analogs. So particularly if your EGFR is less than 30, you're thinking of starting using a renoprotective drug, it will be a GLP-1. However, even with a normal EGFR, a GLP-1 is shown to improve renal outcome.
Dr. Sujay,
Yes, sir.
there is a confidence study that
Yes.
Agarwal,
Which combines empagliflozin with finrenone. So that combination data is already there, which suggests that you don't have to wait for a sequence of SGLT2 followed by MRA. You can give both of them together, which shows better improvement. But again, there I think more than the science, it's the economics which determines what we use.
Very true.
Yeah.
So Jay, can I ask something?
Yes, please.
Yeah. Excellent presentation.
Thank you.
In the slide where you showed that when to suspect non-diabetic kidney disease, you can add one more point, that is shrunken kidneys on ultrasound. That also can be added in that slide.
So unequal kidneys is the point that is there in Harrison. So if you have a difference in the sizes of the kidney on the two sides, it suggests a unilateral lesion. So I kind of took that out because that would be more of a vascular problem. And I did not even mention about the obstructive uropathy because that again would be a non-diabetic kidney disease.
There are patients I have come across where the UACR is slightly raised, but it is raised only on basis of urinary creatinine concentration and not on the basis of urinary albumin excretion. So albumin excretion is, the levels are normal, say they are less than 20 mg per dl, but it is only because of urinary creatinine that we are getting a high ACR.
I would repeat it again, sir. I would repeat it again.
That's okay, but it happens. It happens sometimes. I've come across.
So now may I invite Dr. Manish, our chapter treasurer, to have any comments or questions?
Dr. Vijay, I have one query to Dr. Sujay. Dr. Sujay, can you suggest some biomarker as of now we can use for early?
So wait for about 3 months. I'll share with you a long non-coding RNA paper. The microRNA paper is being written up as well. We found some initial results with the proteomics as well, but I didn't want to talk about it. See,
no issue. Okay, thank you.
Dr. Manish, have you any question or comments?
Very good evening, all. I think Dr. Sujay has illustrated such a beautifully about finrenone specifically, but there is a query: is there any data regarding finrenone specifically in a non-diabetic
that study is on.
patient?
You will get the results somewhere around July, August next year.
July, August. Next year itself, yes, sir. So what is your personal take about SGLT2 inhibitor and finrenone in combination using in the patient of type 2
So
diabetic nephropathy?
Dr. Vijay Vishwanathan sir has already spoken about it. If you look at the confidence trial, which was published in New England Journal of Medicine a couple of months ago, it has compared empagliflozin alone versus finrenone alone versus empagliflozin plus finrenone, which shows that empagliflozin plus finrenone led to better renal outcomes as compared to the individual drugs.
And Sujay, 98% of them were taking ACE or ARB.
Yes, and almost all of them were on an ACE inhibitor and ARB, because that's the standard of care even for the finrenone studies, that is Figaro and Fidelity trial, and the same thing holds true about all of the renal outcome trials of SGLT2 inhibitors.
Yes, sir. Thank you, sir.
So over to among the audience, Dr. Professor R.K. Jha from Indore, who is a member of Bihar RSSDI. So any comment or question from your side, sir? Dr. R.K. Jha, sir. Anyway, I think he's not there.
Dr.
So So with permission of chairpersons, should we conclude this session?
Yeah,
Sure,
absolutely.
sure. Excellent presentation. Thank you. Thank you.
It's all good.
So,
Thank you.
thank you, our National President, Dr. Vijay Viswanathan, sir, for blessing us by inaugurating this virtual CME and giving his valuable inputs throughout the program. I must thank our chapter chairman, Dr. Supriyo Mukherjee, sir, for his valuable presence and encouragement and chairing the session and blessing us by his valuable presence. I must thank Dr. B.K. Singh, sir, our Zonal Executive Committee member from our state, for encouragement and valuable words. I must thank all other faculties, all the respective members, audience, our technical team from 3 Dots for their technical support. And we hope that we will be proceeding with other scientific sessions in due course with some other more valuable and interesting topics. So if Dr. B.K. Singh sir is there, sir, whether you are there or not, Dr. B.K.
Yes,
Singh
yes.
sir.
Yeah.
So,
Am I
so
audible?
your, yes, sir. So your concluding remarks before we conclude.
Actually, I am traveling, so I have switched off my video. First of all, really, I thank to all the participants present in this CME, virtual CME. And really, the Sujay Ghosh is wonderful in presenting the heterogeneity in the kidney disease and diabetes mellitus. And we learn many of the things, new terminology, new things, even the clinical presentation. And there are the first APG student who presented the case of Elstrom syndrome very well, but the few clinical points which has raised by the Sujay Ghosh and Dr. Manish from Devaria, that has very valid and really enjoyed the whole of the CV program. So thank you very much, Sujay, and Dr. All the members who are present. I really thanks Dr. Vijay Vishwanathan sir, Dr. Sujay Ghosh, Dr. N.K. Singh, Dr. Patwari, Ajay Patwari, Dr. Dinesh Agrawal, Dr. Vinesh from Devaria, and all the Supriyo Ghosh, Supriyo Mukherjee, and Shehwal, and all. Vijay, absolutely, this program is totally handled and created and formulated by Dr. Vijay. Thank you very much, Vijay, and we hope the Bihar chapter will continue this type of program off and on every month. Thank you very much.
Thank you, sir, for your blessings.
Thank you.
Now, before we
Thank you,
conclude,
Vijay. Thank you,
sir,
Dr. Vijay. Thank
sir,
you.
sir,
I
sir,
was
sir,
unable
sir.
to unmute. That's why I have taken some time.
No
Otherwise,
problem,
it
sir.
was excellent. It was
Sir,
excellent lecture, and the presentation was also good. All the input has been given by you, the different people is excellent. I'm thankful to you because you have given this link, and I think we will also participate in the coming months. Thank you,
Sure,
sir.
sir. We
And
are
I will
looking forward
inform
to
you
you,
in
sir.
advance.
Sure, sir. We are looking forward to you, sir, and we are thankful for your valuable presence as well. So now, wherever we are, we should stand for national anthem. We should stand up for national anthem. So our technical team to play national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. Thank you, our respected faculties, all the delegates, and I must thank our technical team supported by 3 Dot Life Sciences for their continuous technical support. So before I invite for virtual dinner, may I say goodbye to you all, and I'm inviting you for virtual dinner.
Okay.
Thank you. We will meet again.
That is a good one, Vijay.
Yeah,
That
good.
was the best thing you did.
So thank you once again. Thank you
Good
all
night.
for your interactive session, and we will meet again next month with some other topics, some other
It's a
speakers.
great
Thank
thing.
you. Good night.
Thank
It was a
you.
great
Thank you,
meeting.
everyone.
Good
on behalf
good
of
night.
RSSDI.
Good night,
Dr.
everyone.
Thank you. Good night,
Dr.
Good night,
everybody.
sir. Pranam, sir. Ikatte pranam.
Thank you.
Ikatte pranam, sir.
Okay, bye-bye.